is pursuing that signal. So pretty much grabbing them before they can go dormant.
Right.
And then disrupt that process so that they are then impacted by the chemotherapy.
Yeah, it's a good question. It's something that actually breast cancer has benefited from quite a bit in the sense it's hormonally regulated. And for myself, it's been a great advantage that thyroid cancer is also hormonally regulated. Because but likewise, if you have a hormone-regulated cancer and you have a large tumor and you take it out, you might be taking away a source of hormone response that then tells the other residual cells, well, now we need more of this, right? And so that's going to make the other cells that are hormone responsive potentially grow. This is one of the reasons why in thyroid cancer, a couple of the advantages that you have is you can remove the entire thyroid, right? And then you take thyroid hormone every day, which is relatively easy to take. By taking the thyroid hormone every day, it tells your brain there's plenty of thyroid around. If you stop taking the thyroid hormone, your brain starts going, we don't have enough thyroid. Any thyroid that's around, please grow, which is a terrible example for the cancer, right? There may well be communication signals between bulks of tumors and the individual cells that we do not yet fully understand. So that if you take away the bulk, the remaining cells are getting some sort of signal that's telling them now to grow back, right? And I don't think we understand enough yet about that, but it's a great question.
So I had a guy named Dennis Watson reach out to me. He has a company called Travera.
Okay.
Are you familiar with them at all?
Provera, I'm not.
T-R-A.
Travera, I don't think so.
Okay, because so that they're doing is that they're doing a blood biopsy, liquid biopsy where they are trying to match people with medication that they think would be appropriate for the profile of their tumor.
Yep.
Rather than, and sometimes they're doing off-label and that kind of thing.
Mm-hmm.
I guess my question was going to be, what do you think of it? And clearly your answer is, I don't know.
Sure.
So,
with respect to their specific technology, I definitely don't know. But I would say that the idea of using the blood test to try and select which therapy might be most effective for the patient is a great idea. Like there are different ways to do that, either with the circulating tumor cells or potentially with circulating tumor DNA. It's a little bit more tricky with the circulating tumor DNA because you're just looking at fragments of DNA, whereas with a cell, you actually have the cell that you can test against. But there's still a lot of challenges with that. There are very few of those cells. So there's some bridges yet to cross, for sure.
Right, this is very early, and they're doing
Yep.
like doing the test for free.
Yep.
They're doing the test for free, but outside the traditional clinical trial experience, so it's very proprietary, and I personally have some issues with that because I think that this is very interesting. I'd love to see it in more of a traditional clinical trial where that information becomes public and is shareable and can be used rather than something that's proprietary and they're offering it free to a very small number of patients and they're going to try to extrapolate that.
One of them is me.
Yeah.
But so just quick follow-up, one of the things that we can say confidently for sure is sitting around waiting for a large tumor to come back is not what anybody wants to do, right? Like we want to find ways to address that gap much earlier. Yeah.
Okay, I have a slightly more technical question.
Sure.
But just like something everyone in this room is very familiar with, I think, and we talked about earlier today, is like MBC comes in a lot of different flavors, right? There's molecular subtypes, there's pathologic subtypes, genetic subtypes, blah, blah, blah. They all have their unique vulnerabilities, prognoses, all that. So how much phenotypic variability is there in the processes that you, like these microtentacle formation and all of that stuff? Like, do you see it equally across different subtypes, for example, or?
No, it's a great question. We don't see it equally across different subtypes. We see it more in triple negative. We see it in ones that have undergone what's called an epithelial to mesenchymal transition. So they go away from acting like epithelial cells to essentially acting like connective tissue cells, and the ones that have more stem cell characteristics. But the question that you raise is actually one of the things that I remember from Angela Brody's work that really gave me some optimism for the treatment of cancer, okay? And I think there's an assumption that if you've tried a therapy before and it didn't work well for you, there's no sense in really trying it again, right? But that's not necessarily true, actually. And so the study that Angela Brody did looked at an ER-positive tumor in a mouse, right? And the tumor grew in the mouse, and she treated with an aromatase inhibitor, and the tumor went away. And when it came back, it was ER negative and HER2 positive, right? So now it had HER2, so she could hit it with Herceptin, and the tumor went away again. And when it came back again, it was HER2 negative, but it was ER positive again. So now it could be hit again with the aromatase inhibitor, right? So that's providing optimism, and it means that we don't necessarily need 1,000 different drugs. We might need 2 or 3 really good ones, and a patient can go from A to B to C to A to B to C again, right, for decades of time. And I think there's a clinical assumption that if the therapy hasn't worked in the past, there's no sense in using it again. But as the tests for things like circulating tumor DNA get less expensive and able to do more regularly, you might be able to try going back to a therapy that had worked before. So, or hadn't worked before, but might work now. Yeah. All right. Yes, you had a question.
So if your tumor does go from, excuse me, ER positive to triple negative or
Right.
HER2 positive, does that change the DNA that they're looking for in your tumor with a Signatera?
Not with this circulating tumor DNA test.
No.
No.
Okay.
Typically does not.
So if those go down, but then your tumor's growing,
Right.
how does that even make sense?
Well, so a lot of the circulating tumor DNA tests are based around fragmentation of the DNA, or some of them are actually tailored to specific mutations in the patient. But those are rare because those are very expensive, right? People are trying to go more to the ones that look at broken DNA. So the normal tissues in your body will typically not break the DNA up into little pieces, right? Tumors tend to do that because they get very genetically unstable. So what you can do is you can look at the ratio of normal DNA to fragmented DNA. And maybe it's only 1 part per 100,000, but then it starts to become 1 part per 10,000, 1 part per 1,000, right? And that's telling you that the tumor's growing. But it's not specifically tied to what that tumor is expressing estrogen receptor or not. It's just looking at the fragmentation of the DNA, if that makes sense. Yeah.
And so tests like Signatera are called tumor-informed, which means they take tissue, they're looking at mutations in that tissue, and it doesn't take into account that things will mutate and that maybe 3 years down the road, your cancer is being driven by totally different mutations that are not going to be measured by that Signatera test. So
Yeah,
there's a
that is
difference
true.
between circulating tumor DNA that's kind of more generic and what's called a tumor-informed test like Signatera.
And the tumor-informed tests tend to be more sensitive because you know the specific markers. They also tend to be more expensive.
You
and
know
so
what
they
you
might
know
not be
what
widely
needle you're looking
applied.
for in the haystack,
Yeah.
as opposed to I know there's a needle, but I don't know that it's a red needle. So with Signatera, that's why it's more sensitive because you know what you're looking for. Unless it changes. And
Yeah.
we talked this morning about how cancer is a sneaky SOB and it changes so that it can survive. Of course it's sneaky, but it is stupid because when we die, it dies. So
Yeah, exactly. It's not a very successful strategy from an evolution standpoint.
I'd
Yeah,
rather
and
it
some
more
of the
like
things-
a parasite that we could have that symbiotic relationship. Like, you know,
Right.
yeah, we'd love to never have cancer in our bodies, but if it can stay dormant and it can be like a little parasite, and yeah, I have to feed it with my whatever drug, fine.
Yeah.
You know, I'd rather not have you as my little neighbor for the rest of my life, but I'd, you know, rather do that than the alternative.
So if you do have a case where the tumor is growing, but the ctDNA is going down, would that necessitate a new biopsy?
If it's for that specific type of tumor-informed test where it's dependent on
does.
those mutations
But I also
could
think that's
change.
that's
Yes.
a great point you bring up, because as our cancers change, a lot of times, a lot of us will see that we have imaging. And gosh, all my bone mets are stable, but my liver met is growing. That implies that there's been some change. And I don't think often enough, especially for people that are treated in the community, that are not treated at academic centers, that the obvious thing is like something's different here. This thing is not like the other. and we're not offered biopsies, and either tissue biopsies or liquid biopsies often enough. We should be offered a liquid biopsy, in my humble opinion, which is borne out by some experts in the field, every time we have progression, to see what has changed, to see what mutations have developed. Every single patient, every single person in this room who has metastatic disease should have been offered a clinical trial. And that doesn't happen.
Yeah.
But also, you can have your tissue showing mutations and your blood not showing mutations.
And vice versa. And we talked about it this morning, that you can have multiple different subtypes, areas that have different mutations, and that's the overwhelming question, is what do we treat? A good example of this is people who are triple positive. For years, we can totally ignore estrogen, HER2 is what's going to kill you. We're going to treat the HER2. So a lot of people get great control by doing HER2 targeted therapy. Then things start to grow because they've totally ignored the estrogen receptor. So now more and more people that are triple positive they're getting endocrine therapy to treat that estrogen receptor as well. So we can't ignore one thing just because we think something else is more important.
And in the situation you're describing, where you have a lot of lesions that are not growing, but one that is, probably also makes sense to have a biopsy of the one that's growing.
Yeah.
For your specific lab and the research that you presented, a couple of questions, but generally, how close and what do you see would be like the next jumping off point? I think I kind of saw allusion to maybe using pulse dosing of microtubule inhibitors after surgery. I also saw like maybe the possibility of using the little cartridge as a way to, like a KI score, something that is predictive of tumor proliferation or tendency to metastatic potential. Thank you.
Yep.
So in your opinion, like what are your jumping off points or next goals?
Yeah, it's a great question. And really there's sort of three. You outlined two of those, which is like using the existing therapies that we know could target the spread of the tumor. Are there windows in which we could treat a patient to reduce the risk of that spread? The other would be using the device to do what's called a precision medicine, where you could take a biopsy from the patient, either the lesion that's growing or circulating tumor cells, and test which drug would be most effective. And then the third approach is moving beyond the sledgehammer against all microtubules to something that's a little bit more precise, that we know would attack the tentacles specifically. And we already have a couple of enzymes that operate on that.
I
that we're
love
addressing
you
in
and
our
your
new
baby
effort.
researchers.
I'm kind of fascinated with the whole seeding thing and then the dormancy thing.
Yep.
So a couple of scenarios. I just wonder what you would say about that.
Sure.
Many of us may know, as you travel through advocacy, the patient who is diagnosed de novo and had no traceable primary tumor,
Right.
or stage 0 DCIS patients. I think it really bothers me when DCIS gets kind of pushed to the side as, we don't need to intervene, because all the stage 0 DCIS patients I know are now metastatic.
Right.
So I just wonder, as far as the seeding goes, what is going on there?
Right. So it's a great question, and there's a phenomenon that occurs not just in breast cancer but other cancers, which is called cancer of unknown primary, where the patient presents with metastatic disease, and they can tell from the markers that say they know that it's breast cancer, but they go back and they look at the breast and they don't see any primary tumor, right? And so the way to think about this is there are genetic mutations that can occur in the tumor that cause it to have the ability to spread. And there are genetic mutations that cause it to have the ability to grow. But those are different things. And depending on which mutation occurred first, in the case that you got the mutation to spread, the cells can go everywhere, but they're not able to grow. In the case of the other one, they can grow, but they can't spread. So that's the tumor that you can detect very easily and then remove, whereas the other one that presents itself as cancer is unknown primary because it spreads first and then eventually gets the mutation to grow out, right? It's a great question, though, because this is also something that when you think and you look back at the history of scientific work, there's some things that seem ridiculously obvious now that did not seem obvious at the time. And one of those examples is looking in the mouse models of cancer at what mutations caused cancer. And this fooled not one lab, it fooled the entire field for a while. They found genes that caused primary tumors to grow, but they almost never metastasized, okay? But you think about what they were doing in the lab. They were altering the genetic code, and then they were looking for, did a tumor grow? If a tumor grew, they kept the mouse. If a tumor didn't grow, they didn't do any follow-up studies. So naturally, they found the genes that caused tumor growth, but not the genes that cause tumor spread, right? In retrospect, it seems perfectly obvious, but it's hard to appreciate the blinders that you have on at the time when you haven't discovered it yet, right? The ones that would cause cancer of unknown primary and that sort of thing? Or there are a lot of different ones that can do it. Yes, but this is one of the things that I did during my postdoc at Harvard was we identified a gene that was just involved in self-destruction, and that just limited the ability of the tumor to spread, but it didn't limit its ability to grow. So that's an example of one of the genes that would cause dormancy. But there's not really a comprehensive list of one or the other, but it's because there are a lot of options. Like the tumor can have a lot of options, it's just which order it does it in.
I'm sorry to go on.
Yeah, no worries.
Linda, buttonhole in after this, okay?
Yeah, we can also, those types of genetic mutations? Yes. I think it's not easy to do just based off the mutations, but you can do it based off of the cells. And I think that's where people are working on things like organoids and that sort of thing. But I'm going to stick around for the reception, so please, anybody who has questions who didn't feel like stepping up and asking one, please come by and grab me and just ask me anything. Yeah, sure thing. Thank you all very much.
Or those people that I cut you off because we have to move on. Stuart, thank you so much. I can't thank you enough. Alpha has a couple things to say, so she's going to come up here. These are some awesome questions, and again, I'll give it up for Stuart and his baby researchers that we want to keep in the field.
My stuff is mostly housekeeping because I know I'm standing between you and yummy food. So a couple things that you should see Michelle and Taylor about. 3 things. 1, if you know somebody who isn't coming, somebody's told you I'm not coming, we need to know so we can like cancel their appointment or make sure that we, have that in our paperwork properly. If there anyone who's going to be solo, who doesn't have a partner yet, also see Michelle and Taylor. We're going to figure out a way to make people not solo. And the third is if you have any issues with your app, if your state name is wrong or just something weird, go see them because we're figuring all that stuff out. Okay? I don't.
If
I'm
you have
not
any
100%
questions
yeah.
about the app at all,
Yeah. Ask
Michelle and Taylor.
Yeah.
Okay?
Okay. Tomorrow for the walk, you can wear your T-shirt. If you want to wear it for the walk and then take it off for your meetings, you can do that. Feel free, but ideally wear your T-shirt over your stuff, and then you can partially disrobe for your meetings on the
If
Hill.
you want to totally disrobe, hey.
I mean, Capitol Police are they're there, but they're not. That would get a lot of attention. I'm not sure it would get the kind we want. So,
Can I interject since you just said a word that's a good segue?
sure.
So we are getting some attention, and there is a very strong possibility that ABC DC, so the ABC affiliate here in DC, will be here tomorrow. We'll be covering some of this. So be prepared. There might be some cameras around.
Yes. Not a bill name, but a station name.
Station.
Yes. So tomorrow morning, we're going to meet back in here at 8:30 for breakfast. We're going to leave from the lobby at 9:15. So if you skip breakfast, we're leaving at 9:15 from the lobby, so don't be late. And then the reception is outside now. Any questions? We are going to be walking from here down to 3rd and the Mall because because of the government shutdown, we are not allowed to have an official stampede with a banner on Capitol grounds because of the government shutdown. So our version is public sidewalk, walking, and then standing on a public sidewalk, with the Capitol behind us, someone going across the street taking a picture. We unfurl a banner. We are visible, but we are on a sidewalk, so we don't need a permit to be on a
So
sidewalk.
those of you who've been here in the past, there is no walking down the street with police blocking off the intersections.
Yeah, we don't have that this year.
We are not marching because we don't have a permit because of the shutdown.
Right.
We will be walking on on the sidewalk. We will have the remembrance at the end of the walk.
Right. It will be on 3rd with the Capitol behind us. We'll have the remnant. We'll do everything we normally do. It's just we'll be on the sidewalk instead of in the middle of the lawn. We can chant all that all we want while we're walking. We just are not going to be in the street, and we will have no police escorts. So yes, but we will stay on the sidewalk. Yeah.
We will cross with the lights, people.
Yeah. No jaywalking. Yes, of course they can have the fans. Yeah. Yeah, the fan. You'll have the fans, which anyone who's been here before knows the fan. We'll have the fans, and we'll have the banner to unfurl when we get there, not ahead of time. We are not going to have a mic and a speaker with us because that's part of the thing you need a permit for. But we all have big voices, and we do have the bell, and we'll ring the bell, and we will say names. But we just won't have a mic when we say the names. So thank you for being flexible in the, how do you have all of this with the government shutdown? This is how we do it. So, like Kelly said, we had to do some pivoting and some pirouetting and some special dance moves, but we're here. If there's any questions, please come up to any of us during the reception, and I'm volunteering apparently lots of people to be on the receiving end of questions. I'm happy to answer anything. Just thank you so much for being here. Thank you for being part of this reimagined summit that we added on to the Stampede. I mean, we really tried to make it so that it was a robust 2 days of a real event, not just come in, see each other, and then go to the Hill the next day. So we're really trying to do that. So thank you for being part of the community, for being part of this conversation, for being part of all of the today's programming. And Crystal's trying to get me to say something.
So the reception is actually on the patio. So when you go out to the lobby and you see the restaurant to the left, you're gonna walk that way and it's on the patio.
Walk through the restaurant to the patio outside. Warm, fresh air, sunshine, all those things. So thank you again, everyone, for being here today.
Thank you.
Oh, you're welcome. Happy to be here.